an interprofessional train-the-trainer solution to the diabetic foot care crisis within community shelters. This project sees Niagara College students trained to provide foot health education and to identify foot problems that require treatment, with referrals triaged to local community healthcare partners and centers. Our team currently consists of second-year Niagara College primary care paramedic students, NC faculty and staff, as well as 2 involved shelters and various community partners. This initiative began as a foot screening clinic for clients for participating shelters and has furthered our ability to make community connections that support our ability to triage foot care to community paramedics and local foot care nurse. Furthermore, this initiative has fostered community connections, allowing us to put shoes on our clients' feet donated by local Niagara retailers. Our most recent addition to this initiative has been the first-year PCP and OTA PTA students completing placement hours at one of our shelter clinic locations. Currently, we are providing foot screening clinics at 2 locations, Southwood Community Church and Start Me Up Niagara once a week, with the intention to grow. This initiative followed the train-the-trainer model to share foot care assessment knowledge from the experts to teach NC interprofessional students how to properly assess and triage foot care problems within Niagara region's most vulnerable populations. The TTT model is designed to disseminate knowledge of an expert master trainer to less experienced trainers and has been used in various healthcare settings. The methods we used include first-year students in NC's PCP program who were hired to assist the pilot foot care clinic initiative from the summer to fall 2021 semesters. These students, in conjunction with faculty, site supervisors, and the partnership of Reach Niagara, piloted the foot care TTT model at a local homeless shelter within the Niagara region. Students were educated on the foot care assessments and how to communicate effectively with vulnerable populations like those experiencing homelessness throughout their modules, PowerPoint presentations, and orientations with project staff. Content was verified by the Missioner Institute Shakti Program and NC's nursing faculty. Hired PCP students transitioned to their second year and continued to run the pilot in the fall of the 2021 semester, with the addition of a second location. In the January 2022 semester, first-year PCP and second-year OTA PTA students were invited to participate in 1 clinic day as part of their course placement. Second-year PCP students trained and facilitated the TTT model with these placement students. First-year PCP students were encouraged to apply for the clinic position to assist in taking over when the second-year students graduated at the end of April 2022. This overlap allows for the TTT model to continue, with knowledge being transferred from upper to lower year students. Our findings included that although our original plan was to assess and triage diabetic foot problems, we found that the scope of the diabetic foot-related conditions was much too niche. Therefore, our initiative has been addressing all foot-related issues amongst Niagara's most vulnerable individuals and not limiting to only those with diabetes and foot-related conditions. Moreover, the access to proper footwear is lacking in this population, and is a significant finding that we did not anticipate. Therefore, through leveraging the assistance of NC's SSW students and our PCP students hired as research assistants, we have been successful in establishing community connections whereby businesses have been donating brand new shoes to put on the feet of our clients. Aside from needing proper footwear, clients are mostly in need of foot washing, moisturizing, and nail clipping, and our clinic has not seen many serious foot-related issues needing further intervention. To date, over 35 PCP and 5 OTA PTA students have participated in the clinic as part of their placement, with PCP students being hired and trained using the TTT model. Hired students who take on the foot assessment role in the clinic have said it does take approximately 5 weekly clinic shifts to feel prepared and confident to perform a foot assessment on their own. Future direction and next steps include scaling up the amount and location of clinics offered to serve a larger population within the Niagara region. Secondly, we aim to involve students with other NC health disciplines, including nursing and PSW. These next steps will be implemented in the 3rd and final year of the project. Lastly, we anticipate more knowledge translation at future conferences and academic meetings in hopes other colleges and communities can adopt the TTT and/or foot care clinic model. Thank you.
Hello, my name is Allison Smoke, and I'm one of the principal student investigators on the project that's looking at the provider perceptions of virtual mental health care at Pathstone Mental Health, which is located here in the Niagara region. And this research was conducted by a team of individuals from Brock University and Pathstone Mental Health that you can see listed here. The main goals of our project were first to evaluate the effectiveness of virtual mental health programming at Pathstone. It's a new program that launched with the start of COVID-19 pandemic and lockdown requirements. So we really wanted to make sure that what we're doing is a best practice and we're able to deliver the best care possible. So first off was that evaluation. And then we also wanted to see if we could develop a decision aid tool to kind of figure out who is virtual care best for, who is in-person care best for, and maybe who is that hybrid flex approach appropriate for, and in what instances are each of those modalities appropriate. And with that, we wanted to be able to create supports for those that were entering anything with a virtual component. So more in-depth training on this is what you need to know, and these are the resources that you have prior to starting virtual care. So with our project, we first started off with a literature review, research ethics board application. I'm not going to dig in too much into those today, but you can see our full report. It's located here. You can see the QR code at the bottom of the poster, and you can access all of the information that's much more in depth than my little 5-minute presentation will be. Then once our research ethics application was done, we went and we developed a questionnaire. We worked with patient partners to develop these questions and then distributed them to the 3 stakeholder groups that we had hoped to reach, which was clients age 12 to 18, those clients' parents and guardians, as well as providers at Pathstone Mental Health. Due to non-response bias, unfortunately, we were not able to analyze the results of the clients or their parents and guardians, but we are able to talk today about the provider responses that we did receive. So as you can see here, a majority of the providers that did answer the questionnaire are female. We had 83% that identified as female, with, again, a majority of our providers over the age of 40. 72% of people shared that they were over the age of 40. One of the main findings within the questions that we had on our questionnaire was related to emotional connectedness. So providers shared, as you can see in these tables here, that not only are they less emotionally connected to their clients, but they're also less emotionally connected to the parents and guardians of their clients. So that's something that when we saw this within our questionnaire results, we really wanted to be able to have that conversation about why does this and how can we better support that. So you'll notice in a second that we're going to talk about that a little bit more. We also found within our questionnaire that privacy is a large concern for many providers regarding their clients' privacy specifically. So that's, again, something that we identified this theme, and we're going to discuss it further with when we have our focus groups that I'm going to discuss now. So again, we took the main key findings that we had from our questionnaire, and we developed some loose guiding questions for our focus group to help facilitate a really deep conversation about the findings that we'd found. So you can see here that there's a few direct quotes, but I'm kind of going to pull on the main themes that we found. So the first one was privacy. Again, like I said from the questionnaire, providers are concerned about the level of privacy. We had one provider share that they often have clients that will start whispering and get really quiet when they're talking, and the provider can no longer really hear them as clearly, but it's because often they're concerned that maybe the person that they're talking about is outside the room, and that could have repercussions and kind of impact their safety at home. So that's definitely something that's important to consider. The next conclusion that we kind of found was related to that making connections and emotional connectedness piece. Providers shared that they want to have further training on the opportunities where they can foster that therapeutic relationship. When you're in person, you're able to maybe play board games or go on a walk around the facility with your client or go to the park that's located on site. But when you're online, providers are less sure of what resources and what tools are available to them that would help additionally foster this relationship. So they want more training regarding that. And then the last piece that we talked about was management. So emergency management is also a huge component related to virtual care. We had a provider share that they were on a call with a client. The client expressed suicidal ideations and then closed their computer, and the provider had no contact with that client at that point. So that's when that emergency management plan, luckily it was developed and they were able to use it, but it obviously still adds undue stress onto the provider. So that's definitely something that needs to be thoroughly developed and regularly updated throughout that process. Once again, as I mentioned, our full report is available. You can just use that QR code in the bottom of the poster there. If you have any questions, feel free to email us. You can send it to research@pathstone.ca, and both Holly and I will have access to that. Thank you.
Hello, everybody. My name is Colleen Woodhouse. I'm here presenting today with Caitlin Moole, and we're going to be presenting our project on building the infrastructure for social prescribing at Quest Community Health Center. And before we get started, we'd like to shout out the rest of our team, which includes Dr. Madeline Law, Erin Walters, Tara Pasco, Joanna Linsdale, and Jenny Stranges. So, for background, according to the Social Prescribing Network, social prescribing is a means of enabling healthcare professionals to refer patients to a link worker or co-design a non-clinical social prescription to improve their health and well-being. Throughout 2020 and 2021, Quest Community Health Center partnered with the Interprofessional Education for Quality Improvement program at Brock University to help build the infrastructure for social prescribing. There is growing interest in social prescribing across Canada, and this is largely due to the fact that Alliance for Healthier Communities recently conducted Canada's first social prescribing pilot between 2018 and 2020. The results of this pilot were very promising, so now researchers are asking their colleagues to help build the evidence base around social prescribing in Canada. Our country's first social prescribing pilot was conducted in 11 community health centres across Ontario. Quest Community Health Centre, located here in St. Catharines, was not involved in this initial pilot. But they did run a social prescribing client survey, and results from this survey revealed that clients both want and need social prescribing. Nearly 3/4 of respondents said that they did not attend programs or groups offered at Quest. Over 40% of clients said a barrier preventing them from attending these programs was that they simply weren't aware of the options. And nearly half of the clients said that it would be helpful to be able to talk through their options or walk through the entire process with a staff member. These results made it very clear that Quest clients both want and need social prescribing. Therefore, the aim of this work was to develop the infrastructure for social prescribing at Quest.
So, drawing on the social prescribing guidebook that was released by the Alliance for Healthier Communities, which conducted Canada's first social prescribing pilot, team members worked together to create the infrastructure for social prescribing. One of the things that we did was create a process map to outline each step in the social prescribing pathway. This was a really important part of this process to ensure that all staff members were on the same page about the social prescribing pathway. We also created a social prescription pad for healthcare providers. This contains the client name, provider name, date, and 6 social prescription options. They include looking to connect with others, looking for a hobby, looking to better my mental health, looking to better my physical health, looking for support with my basic needs, and other. We also developed a social prescribing menu for clients and link workers. The menu contains a comprehensive list of internal and external resources that are divided into 5 menu options: social connection and sense of community, hobbies and common interests, mental and emotional health, physical health, and basic needs. We also developed an evaluation plan right from the outset of this project. This plan consists of a convergent, parallel, mixed methods approach, which includes a process evaluation to evaluate the implementation of social prescribing and an outcome evaluation to evaluate the effectiveness of social prescribing. We also worked with data experts to establish social prescribing documentation in the electronic medical record. This was a really important part of this process to ensure that social prescribing would become embedded into practice. We also conducted social prescribing training sessions for staff members, including separate sessions for healthcare providers and link workers. And finally, we held a social prescribing launch session for clients. This session allowed us to increase clients' awareness of social prescribing and also reconfirmed for us that clients want and need social prescribing. So one of the things we did during the session was ask clients what aspects of wellness they would like to improve. 100% of clients said that they would like to improve their emotional wellness. 80% of them said that they would like to improve their physical and social wellness. And 60% of them said that they would like to improve their financial and environmental wellness.
Okay, so results from this project include that our team members successfully created the infrastructure for social prescribing. And something that helped us a lot was the Social Prescribing Guidebook by Alliance, and this played a crucial role in guiding this work. So the time and effort that team members put into building the infrastructure for social prescribing was critical to the successful launch of the social prescribing program. Through PDSA cycles, improvements will be made to the social prescribing pathway over time. A convergent parallel mixed methods approach will be used to conduct a process and outcome evaluation of social prescribing. And with social prescribing gaining momentum across Canada, we anticipate that this work will help to advance the evidence base of social prescribing in Canada.
Hello, my name is Marty Mako. I am the Commander of Mobile Integrated Health with Niagara Emergency Medical Services, and this poster is titled EC3P, Expanding Care by Paramedics to Palliative Patients in the Niagara region. And although I'm representing EMS today, I just did want to recognize all of the other partners listed on this screen because this project certainly could not have been delivered by EMS alone. Starting with a bit of an introduction, it is well documented that a significant number of people who are at the end of their life do prefer to die at home with the appropriate level of supports in place. There is often a network of home and community care professionals to support these patients to provide comfort and management of their symptoms at home. But sometimes there is limited in-home support, and these service gaps have been increasing during the pandemic. So when there is a crisis or breakthrough pain episode, paramedics are uniquely positioned to provide in-home support to those who call 911 and are at end of life. The EC3P project at Niagara EMS, which is the first of its kind in Ontario, includes 30 specially trained paramedics who are available 24 hours a day, 7 days a week, and can provide medications and care beyond the standard emergency care provided by paramedics. This EC3P project has been active since late 2019, and the Ministry of Health approved this research study, which has supported over 400 palliative patients in the Niagara region, reducing hospital transfers by 18% during that time. And this has met a gap in community-based services through early identification of those who could benefit from community palliative support. It truly is meant as a gap filler, not to in any way overlap or duplicate services provided by other palliative care teams. We thought we'd share a case study just to understand what this impact is with individuals in the community. This is a real case study, but the names have changed. So Joe is a 74-year-old man living with pancreatic cancer, and he's now home after a recent hospitalization. His care team includes his family physician and community palliative care team, as well as home care. Joe and his wife, Mary, decided he wants to focus on pain and symptom management at home. He's hopeful to avoid any further hospitalization and wants to remain at home until his death. Over the next few days, Joe's condition worsened. He could no longer safely get in or out of bed. Mary called the visiting nursing agency requesting help and was told that a nurse could not come to the home for a few hours. So a decision was made to call 911 to receive immediate support from the EMS specially trained palliative mobile integrated health team. The MIH team assessed Joe and provided appropriate medication, which can be given only by this team, as well as verbal support and comfort for Mary and Joe. After seeing Joe, EMS contacted his community care provider for a follow-up visit and confirmed that repeat medication was awaiting delivery from the regional pharmacy. The visiting nurse did come on Friday afternoon, and after giving medications, provided Mary with instructions to administer the medication herself, as no nurse was available until Saturday night. Joe then died peacefully Sunday afternoon at his home. The lessons learned from this case: without the palliative mobile integrated health team, Joe would have likely gone to hospital and died there, which was against his care plan wishes. Also, coordination and communication between the paramedic services and home care helped to provide that seamless care to ultimately meet Joe's wishes. There have been a number of lessons learned from the EC3P program so far. A few that I'd like to highlight do include that clear communication between all care providers, improving the patient care coordination experience, and help with system navigation, which we hear is often a source of patient concern and confusion. We've received a high level of satisfaction from patients and their families with the timely response to their needs in their home environment. The fact that this program is filling significant gaps in some areas of home and community care, which we've seen has been exacerbated during the pandemic. Paramedics do benefit from ongoing education and feedback to help build their knowledge and skills in this area of work. It's important, I would say critical, to keep patient goals of care and their wishes at the center of this work, so it does remain client and patient centered. Paramedics themselves have a feeling of making a difference in working with palliative patients, and the fact that they have the tools and permission to do this, that it is supported from the Niagara EMS leadership top down. The EC3P project team is more than willing to share their learnings and evaluation results with other communities who might be willing or interested in starting a similar program. The fact that we make real-time quality improvements to the program throughout, we're not waiting until the EC3P program is done to make any changes. We make them in real time. And we are collecting data rigorously throughout the program to demonstrate its impact. Future plans and next steps include continuing with the research phase of the project until January 2023. We're also engaging with palliative projects across Ontario to share our lessons learned, since each program is being implemented a bit differently. We're continuing to collect data, analyze and review it from a quality perspective, and we have ongoing discussions with the Ministry of Health about future plans and longer-term sustainability. Thank you very much for listening, and I'd be open to any feedback or questions for those that are interested in learning more.
This video summarizes my research on the growth in cannabis stores, sales, and users in Canada. After Canada legalized recreational cannabis in 2018, provincial governments began to regulate retail sales. Some provinces opened very few stores to discourage non-users from starting. Others licensed many stores to encourage existing users to buy legally. What was the best balance? Meanwhile, some municipalities banned cannabis stores completely. A few of those bans were temporary, but many remained in place almost 3 years later. Was that wise? My research examined increases in licensed cannabis stores, legal cannabis sales, and overall cannabis users from 2018 to 2020. Data on sales and users came from Statistics Canada, while store numbers came from provincial regulators. I found that store growth was strongly related to sales growth. It explained 46% of the quarterly variations in provinces' sales. For example, in Alberta, stores and sales both climbed rapidly. And in Nova Scotia, stores and sales both remained flat until late 2020. By contrast, store growth was only weakly related to user growth. It explained just 8% of quarterly variations in provinces' users. For example, while store count soared in Alberta, user numbers just bounced around. But in Nova Scotia, user numbers jumped while store numbers stayed constant. It seems that opening more licensed stores greatly increased legal sales, but barely affected user numbers. Apparently, most of the user growth was due to legalization's other effects or to existing trends in society. The results also imply most legal sales went to existing users, not new ones. One potential explanation for store growth being disconnected from user growth is the black market. If illegal dealers were already widespread, then opening more licensed stores would greatly increase consumer access to legal cannabis, but only marginally increase access to cannabis overall. My findings suggest that government should allow enough stores to ensure easy access rather than worrying about having too many. As well, municipalities should drop their store bans, as those discourage legal buying but seem unlikely to discourage new users. Similar suggestions might apply in other countries where illegal cannabis is widespread. For more information, please read my report in the journal Drug and Alcohol Dependence.
Hello, my name is Sabrina Buchanan. I'm a graduate student in the Behavioral Health Sciences Research Lab at Brock University, working in collaboration with Dr. Phil Wilson, Dr. Diane Mack, and Dr. Tanya Nagpal. And today I'd like to share with you our work on the topic of supporting physical activity during pregnancy. At the beginning of this year, we completed data collection for this project, and I'm excited to present our findings here today. To provide some context, the Canadian Society for Exercise Physiology encourages regular physical activity throughout pregnancy, with specific recommendations of 150 minutes of moderate intensity physical activity, spread out over at least 3 days per week. However, the vast majority of pregnant individuals, and in fact over 3/4 of the pregnant population, do not meet these guidelines. So the purpose of this study was to examine whether the method used by an exercise professional to communicate physical activity information to a pregnant client impacts participation in physical activity. This research was grounded in the concept of motivational interviewing, a client-centered counseling approach that seeks to guide an individual towards making positive behavior changes, and has been explored to a degree in the pregnancy literature. Based on this motivational interviewing framework, 2 opposing communication styles were tested, as we will see on the next slide. Using Qualtrics survey software, participants were assigned one of the 2 study conditions in the form of a written vignette. The vignettes portrayed a hypothetical consult taking place between the exercise professional and a pregnant client who is currently inactive. The pregnant client was given this inactive status to allow for room to see potential growth in physical activity participation. Each of the 2 conditions depicted the exercise professional using a different communication style, being either guiding, which used motivating and supportive language, or directing, which involved specific directions or advice to be followed. Participants were then asked to respond to a series of 6 questions which allowed us to assess whether our vignette manipulation was functioning as intended. Specifically, whether participants could detect certain aspects of the vignette which differed between the 2 conditions. Participants then provided responses pertaining to the physical activity level of the vignette target that they had read about, looking to 3 time points in the future. Our analysis of the manipulation check items revealed scores in the expected direction, which is indicative that the vignette intervention performed as planned. Moreover, as can be seen in the graph on the right, the main analysis revealed that those in the guiding style condition, as shown here in blue, provided reports of higher physical activity on average than those in the directing style condition, shown in red. The mean values can be seen in the table at the bottom of the slide. Importantly, results also demonstrated a significant decrease in physical activity levels throughout pregnancy in both study conditions. The decline from both the first to the 3rd trimester, as well as the 2nd to 3rd trimester, was considered statistically significant. Overall, findings point towards an advantage of the guiding communication style for improving prenatal physical activity. This may be due to the elements within this vignette emphasizing client autonomy and related motivational features, which are associated with greater physical activity participation during pregnancy. Detected along with this group difference was a decrease in physical activity throughout pregnancy, as is commonly seen in literature. There was no evidence of an interaction between this time effect and the effective condition on physical activity. Yet the use of a client-centered communication approach remains appealing. In accordance with this study's findings, exercise professionals may find value in adopting a guided communication style when possible, ultimately honoring the mindset of the client as the expert of themselves. Thank you very much for listening. I appreciate your time and am open to receiving any questions about my work.
Hello, my name is Anusha Chacko.
And my name is Savannah Nui.
We recently just finished completing an ICRIP project, which is the Interprofessional Education for Quality Improvement Program at Brock University under the supervision of Dr. Madeline Law.
Our IEQUIP project is on the Vitra Program, which is also known as the Violence Threat Risk Assessment Protocol with Pastoral Mental Health under the supervision of Ryan Andres and Aaron Clayton.
The Vitra Program is a community protocol that is used to promote the safety and well-being of youth by responding to incidents done in the community of high-risk threats and violence done by children and youth.
These high-risk behaviors may include possession of weapons, bomb threats, sexualized behavior, fire settings, and such more. This program aims to reach out to individuals that might have a high-risk behavior. These high-risk behaviors can be referred from either the school, hospital, or within Pastone, where the individuals are assessed and given an appropriate number of sessions to hopefully reduce the high-risk behaviors. This project is important because it allows us to find the right approach in bringing individuals to the appropriate program. It also teaches us what threat assessment means, having an overall better understanding on youth violence.
When first looking into this program, we had to figure out what we can do to make the Vitra process run more effectively. Therefore, from September to December, our objective was to increase the appropriateness of referrals to 80% to the pastoral mental health team.
The first issue we came across was that many of the internal staff were unaware of what actually the Vitra process was. Our method during these 4 months was to increase the internal knowledge and awareness of the Vitra service pathway. And by doing this, we developed a process map for staff and workers to read and understand the criteria of what defines a high-risk threat behavior.
The results from this were audited by high-risk therapists for appropriateness, and we were then able to bridge the gap between internal knowledge. Our January to April objective was to provide the Vitra team feedback on the Vitra process and services done by different stakeholders.
Our method was to create 3 surveys which include patient, guardian, and therapist surveys to hear each perspective to determine the effectiveness of the referral process and other factors of improvement.
Now that we're at the final stages of our project, our next step is to hopefully set a date with the Vitra staff to discuss our project on the 3 surveys that we just currently made, as well as receiving feedback for further improvement before the projects get implemented.
Even though we are done with the IACRIP program in the school year, we will still be continuing our working with the Vitra project over the summer. So thank you for listening.
Hi everyone, my name is Sandra Dillo. I'm a PhD student at Brock University. Today I will be presenting perceptions of peer support for exercise in members of a Niagara-based program for those with mobility-related disorders. I would like to acknowledge my co-author, Dr. Kimberly Gamage, and the Brock Niagara Center for Health and Wellbeing. Over 22% of Canadians 15 years of age and older live with at least one disability. Pertaining to the study, we focused on physical disability. Spinal cord injury occurs when damage is sustained to the spinal cord or spinal nerves, while multiple sclerosis is a common chronic and progressive neurological disease that affects the central nervous system. Long-term changes lead to everyday physical and mental health challenges such as chronic pain, fractures, loss of balance, and depressive disorders. Physical activity can mediate long-term and secondary health complications and therefore improve overall well-being. In terms of physical activity, there is higher inactivity rates in those with spinal cord injury or MS than the general population. Evidence suggests that the low activity rate is related to barriers such as accessibility, exercise program options, and severity of injury and disease. As such, interventions to promote physical activity and reduce barriers in these populations are required. Peer support, which has been effective in increasing physical activity in children and older adults, shows promise in promoting exercise in other populations. Perceptions of individuals in established spinal cord injury or MS exercise programs remains unexamined. The purpose of this study was to qualitatively investigate perceptions of peer support in physically active individuals with spinal cord injury or MS. 12 participants, 3 males and 9 females, 2 with spinal cord injuries and 10 with MS between the ages of 33 and 65 years from a Brock University affiliated exercise program known as Paracord were recruited. Program membership ranged between 6 months to 3 years, and the exercise facility itself is equipped with accessible equipment and staffed with registered kinesiologists and undergraduate and graduate kinesiology student support. Participants were asked to complete a demographics and physical activity questionnaire. 3 semi-structured focus group sessions with up to 6 participants per group were conducted. Participants were asked questions related to exercising, such as likes, dislikes, barriers, and motivators, information and dissemination of physical activity, and their perceptions of peer mentors. 2 themes emerged from the analysis: 1, role of external and internal factors in exercise participation, and 2, perceptions of peer support. In the first theme, examples of external factors included accessibility, such as access to expertise and access to an exercise program specific to their needs, and socialization of the exercise program. Members in this program have their own separate space. It allows for multiple members to exercise at the same time, which can lead to a more sociable visit. Participants mentioned a sense of belonging and positivity they felt when participating in the exercise program. In identity, participants mentioned a new set of physical, mental, and social challenges. Mike explained, in my case, both the pool and Brock, the Power Curve program, are a new part of your social identity, and I think that's very, very important to have that. A new diagnosis means starting a new life, new identity, and reinventing themselves. The second theme explored the perceptions of peer support. Participants questioned who the mentor should be, whether it's a program member, staff, or student, characteristics of a mentor training and support. The focus group also spoke about the structure of the exercise or that peer support program. Several highlighted the importance of matching mentors and mentees by, for example, the severity or nature of their conditions, obligations or commitment to the program as a mentor, type of support, such as long-term versus short-term, exercise and or emotional support. Results showed that removing and recognizing specific barriers such as accessibility to facilities and programs and equipment increased participation in physical activity. It is important to recognize spinal cord injury or MS diagnoses can be life-altering. An adjustment to changes can be difficult and ongoing. There is no clear consensus on how peer support should be organized. However, it is greatly recognized and valued. Participants did highlight that support, such as emotional and exercise support, is necessary, especially early on with initial diagnosis occurs. As such, future studies could explore combining the peer support role of a, for example, mentor with exercise support from, for example, student trainers to establish support teams with differing expertise. A special thank you to the members of the PowerCode program for their time and participation in this study. For anyone interested in our exercise facility and programs, please contact us below. Thank you for listening.